Good morning, colleagues. So great to be here with you. I am really so honored to introduce our rounds today, Fighting the HIV, COVID-19, and Mpox pandemics in Washington, D.C. through academic collaborations with D.C. Health, clinicians, and community by Dr. Amanda Castel, who you're going to meet in a moment and hear and just be so inspired to even hear about. But first, we want to hear from Chris, who's going to tell us a lot of things that we want to know.
Hi, everyone. Good morning. So two things that I'll touch upon. So this webinar is eligible for 1.5 credits of continuing education. I have a link that I will put in the chat towards the end, more when we get to the Q&A part of this. And then as an announcement, our very last rounds of the season in spring will be 2 weeks from now on June 6th with Dr. Roger McIntosh. And that will sort of close out our session. So thanks, everyone. And I'll throw it back to you, Susan.
Thank you again. And I'm going to introduce Dr. Amanda Castel, who is a tenured professor of epidemiology at George Washington University Millikan School of Public Health and Pediatrics at the School of Medicine and Health Sciences. She is an infectious disease medical epidemiologist whose research focuses on the HIV prevention and care continuum. She joined the faculty at the Millikan School of Public Health in 2006, where she was the chief epidemiologist for over a decade on a public health academic partnership with the DC Department of HIV and AIDS, Hepatitis, STD, TB Administration. Since then, she has successfully developed a large NIH-funded research portfolio, including as principal investigator of the DC cohort, a longitudinal multi-site cohort of over 12,000 people with HIV in DC. Dr. Castel is co-director of the DC Center for AIDS Research and the academic lead for the DC CFAR Ending the HIV Epidemic Scientific Working Group. She is an invited commissioner for the Lancet HIV IUPAC Commission on the Future of Urban HIV Responses, serves as an external advisory board member for several CFARs, and previously has served on the NIH's AIDS Research Advisory Council. She has over 100 peer-reviewed journal articles, an immense and incredible record of grant funding, clear dedication across grants and publications in elevating the successes and ongoing need to elevate DC in the settings of HIV, COVID-19, and Mpox. And looking at her CV, I want to say that she has worked widely, nationally and internationally, as well as in DC. And her CV would just blow you away. I think everything that I've said is wholly an underestimate of what you would see if you read her CV, but it's really an honor to warmly introduce you, Dr. Castel.
Thank you for that very kind introduction, Susan, and also thanks to Chris and to everyone at the Center for inviting me for this opportunity to share the work that we've been doing in DC in collaboration with the health department, with clinicians, and with community. So I'm going to jump right in and let's see. Hopefully you all are you seeing the presentation?
Yes, we are.
Okay, great. All right. Let's see if I can get the slides to advance. There we go. All right. So I'm going to take about the next 45 minutes or so to really take you through my kind of personal experience working at GW in relationship with our partners at the DC Department of Health, to explain to you how we have used these relationships, these clinical and community partnerships, to respond to not only the HIV epidemic, but the COVID-19 pandemic and the most recent Mpox outbreak. And then I'll share a few lessons learned and concluding thoughts. So the learning objectives are for you all to leave this talk with an understanding of the epidemiology of HIV and emerging infectious diseases in Washington, D.C., to recognize how public health and academic partnerships can be used for this epidemic or pandemic response, and then also to highlight the role of longitudinal cohorts in monitoring ending the HIV epidemic efforts. So I want to start with a little bit about the DC Department of Health GW Public Health Academic Partnership. So when I joined the faculty at GW in 2006, the DC Department of Health HIV program was really under very close scrutiny. They had not published any AIDS data in the last 5 years on the city. And while they had been collecting data on HIV, that data had also never been published. The CDC at that point was requiring the dozen or so jurisdictions that were still doing code-based HIV surveillance to transition to a name-based HIV reporting system. And then DC Appleseed, which is kind of a local watchdog organization, had decided to issue report cards grading the city's response to the HIV epidemic. And here's an example of that first report card on the right-hand side. And you can see that the grades ranged from, as low as a D to as high as a B+. And then they even gave us incompletes for areas around surveillance staffing and HIV data. And so this was the context in which we established this public health academic partnership to really try to support the HIV/AIDS administration. Through the partnership, we were tasked with conducting a technical evaluation of the program, as well as providing recommendations and support to really strengthen the surveillance systems. So the partnership consisted of two main activities, core HIV surveillance support and national HIV behavioral surveillance. The core surveillance really was basically myself as an embedded faculty member working under the title of chief epidemiologist. Eventually, Dr. Rupali Doshi would take over that position in around 2017. We had a full-time research analyst and 4 to 5 graduate students that worked with us. And basically, together with the surveillance and epidemiology team, we assisted them with data cleaning, analysis, and the publication of eventually 14 annual surveillance reports. The second component was the National HIV Behavioral Surveillance Program. And this is, as probably many of you know, an annual community-based CDC-funded surveillance program, which focuses annually on men who have sex with men, persons who inject drugs, and then high-risk heterosexuals. This study was led by my colleagues at GW, Doctors Irene Coe and Manya Magnus, and they have an entire team of research staff and graduate students that helped to implement the study. And findings from NHBS have also been reported annually through this partnership, and they have more than 20 peer-reviewed publications to date. So as this timeline shows, again, I came into this in 2006, but over the next 15 years, between 2007 and 2022, we would really observe pretty significant gains in our efforts to fight the HIV epidemic in DC. You can see where that first red circle is in 2007. The number of new HIV diagnoses peaked at almost 1,400 cases in the city in just that 1 year. And at that point, we had an overall prevalence of about 3%. But you can see also that by 2022, we had made really a lot of progress in that there were 210 new diagnoses reported, and our overall prevalence has come down to about 1.7%. So there are many activities that contributed to these gains, and I'm just going to highlight a few for the sake of time. In my capacity as chief epidemiologist, we helped with implementation of name-based HIV surveillance reporting. We organized listening sessions, educational sessions for our clinical providers to really orient them around these new reporting requirements. We also worked hand in hand with the surveillance team to publish the first HIV data and eventually the first integrated surveillance report that included not only HIV and AIDS data, but hepatitis, STD, and TB data as well. We also assisted the city with implementation of routine HIV opt-out testing. We evaluated the programmatic impacts of this approach and the lessons learned from our experiences doing this. And we also conducted linkages of HIV, hepatitis, STD, and cancer registries in an attempt to really better understand the magnitude of these syndemics in the District of Columbia. One of the areas that I think we have in common with places like New York City and San Francisco is that we were really one of the first cities and first health departments to utilize surveillance data for what I say as action. So we are one of the first cities in the US to measure community viral load, and we contributed to the development of the CDC guidelines for how to calculate and define community viral load. We also led some of the first activities in which surveillance data were used to identify people out of care and to actively re-engage them in care. We called that the Recapture Blitz. And as part of the Recapture Blitz, we worked with the Ryan White Care Act funded clinical sites in the city. We identified at that time 686 clients that had evidence of being out of care. And we used surveillance data to actually go back and to determine if they had been out of care and if they required re-engagement. We then determined whether those people with HIV who were successfully re-engaged in care were more likely to remain in care and to be virally suppressed than those that we weren't able to capture through the Recapture Blitz. And you can see from the figure in the bottom right corner there that that they were significantly more likely to remain in care and to be virally suppressed 18 months post re-engagement. So these efforts, even though they were very labor intensive, actually did help to get people back into care. We also spearheaded efforts to use surveillance data for research purposes. And that really started through what was kind of a precursor to some of the EHE activities now, but these were these enhanced comprehensive HIV prevention planning or ECHIP project activities. The National Institutes of Health funded 3 rounds of ECHIP activities. The first round, we used our surveillance data and our data on routine HIV testing implementation to look at provider attitudes towards PrEP. We partnered with CFAR colleagues at Baylor and in Houston and University of Miami. In the second round, we built off that work of the Recapture Blitz and actually found these clients and interviewed people who were at different stages of the care continuum. We asked people to self-report where they saw themselves on the continuum. And interestingly, we found that most people, even though they had been out of care, still felt like they were fully engaged in their HIV care, which was kind of a message to us that we really needed to help people understand the chronicity of HIV. And then in the third round, we used our surveillance data to identify areas in the city that had poor care continuum outcomes in order to do targeted testing. And we did this by partnering with Community Education Group, which is a community-based organization that had expertise in reaching marginalized populations in DC. We tested individuals with them, and as soon as somebody was identified as HIV positive or out of care, they were able to immediately drive that person to a care site and get them re-engaged. So where are we now with the epidemic in DC? Currently, there are 11,747 people estimated to be living with HIV in DC as of 2022, based on surveillance data. You can see here that the vast majority are Black. 46% of those individuals are Black men and 23% are Black women. And out of every 10 Black men living with HIV in DC, about 6 of them have been infected through male-to-male sexual contact and 2 through heterosexual contact. And then out of every 10 Black women living with HIV in DC, you can see that 7 of those Black women were infected through heterosexual contact, and then about 1.5 through injection drug use or some other mode of transmission. With respect to the DC HIV care continuum, we actually are doing pretty well with respect to knowledge of HIV, being linked to care, and being retained in care. But you can see here that about 69% of individuals are achieving viral suppression. And so we still have about 31% of individuals who are not virally suppressed in DC. And of course, we worry about those individuals being not only at risk for their own health, but also for the risk of onward transmission. So as I'm sure all of you all are familiar with, in February of 2019, the Department of Health and Human Services launched this initiative to end the HIV epidemic, A Plan for America, which had particular emphasis on areas of the United States, including Washington, D.C., that accounted for a substantial burden of HIV infections. And the goals here were to diagnose all people with HIV as early as possible, to treat people living with HIV quickly, and to get to sustained viral suppression, to prevent new transmissions using biomedical interventions such as PrEP, as well as syringe services programs, and of course to respond quickly to potential HIV outbreaks so that we could get needed prevention and treatment services to people who may need them. So in alignment with the EHE plans, the DC Department of Health also launched its own Ending the HIV Epidemic plan. You can see in the top right corner, it's called DC Ends HIV. Their plan was actually launched in 2016 and it was updated in 2020. You can see that the goals are set for 2030, which include kind of the traditional 95, 95, 95. But DC also has a goal of having fewer than 20 new HIV diagnoses annually by the year 2030. And while the city has made a lot of progress and a lot of strides in getting to these goals, we still see from the graph on the right that there are still gaps with respect to getting people with HIV into treatment, as well as getting them virally suppressed. And so capitalizing on the strength of those health department collaborations, the clinical collaborations and relationships built through ECHIP, through routine testing implementation, through name-based reporting implementation, and also through a unique partnership that we have with NIH called the Partnership for AIDS Progress. In 2009, we were able to launch the DC cohort longitudinal HIV study. And in sum, the cohort is an attempt to try to capture longitudinal data on people who are getting outpatient care at a variety of clinics in Washington, D.C. And we collect information on their risk factors for HIV, all of their diagnoses, whether HIV related or not, all of their treatments, lab results, and procedures as well. We have really tried to make this a citywide initiative. We have 14 and soon to be 15 clinical sites that participate that include academic, community, and government clinics. We have pediatric clinics. We have, we kind of always say we have from pediatrics to geriatric participants in this study. And the backbone of the study really is that we consent individuals and then we do a limited amount of retrospective data collection, but we really rely on export programs from the site's electronic medical records that are uploaded into a centralized electronic database on a monthly basis. In the spirit of our continued collaborations with the health department, we conduct a periodic linkage of our cohort data with DC Department of Health HIV surveillance and other infectious disease databases, and I'll show you a little bit of that data. We have active community participation in the form of a patient community advisory board. Some of the members of the CAB have been with us since the study's inception in 2009. And we launched the study enrollment in 2011 in January, and since then, we have over 12,800 participants consented as of the end of last month. And about half of those participants are what we consider to be active. So we have evidence that they're actively in care. Importantly, the cohort is really transitioned from being an observational cohort to a platform to do other research studies and interventions. And I'll talk a little bit about some of those examples as we move forward with the talk. So the demographics of DC cohort participants really mirrored those of people living with HIV in DC. You can see here that the median age is about 56. The vast majority of participants are Black. About 70% are male. We have kind of a mix of transmission risk factors, but about 43% are thought to have been infected through male-to-male sexual contact, and another 34% through heterosexual contact. Most of the people in the cohort are ARV experienced at the time of enrollment. And then you can see that we also track common comorbidities. I've just highlighted a few here, but about 30% of our population has hypertension, about a quarter have mood disorder, and then about 10% have hepatitis or diabetes, and about 4% have hepatitis B. We have compared people who have enrolled in the DC cohort to individuals who are in the HIV surveillance database, and demographically they are similar. I would say really the big difference here is that people in the cohort tend to be more engaged in care, which is not surprising because we enroll them when they come in for a care visit. And then just to, again, kind of clarify, I'm showing you data on 6,600, what we consider to be active participants, because those are individuals who are actively seeking care. They have evidence of a CD4 or viral load lab or an HIV encounter in the last 18 months. So the cohort team has published more than 55 papers at this time, including those focused on linking clinical and surveillance data, monitoring the quality of care, applying national standards for HIV care, identifying disparities in HIV outcomes, including viral suppression, looking at things like distance to care using GIS, as well as focusing on comorbidities such as STIs, metabolic conditions as well. We've also used the cohort to really describe some clinical conditions and comorbidities among people with HIV. And again, these are just a few examples, but we've looked at treatment interruption among the pediatric population, dyslipidemia, metabolic conditions. We've looked at pharmacological treatment of psychiatric disorders, cancers associated with HIV, as well as cardiovascular, pulmonary cancer, mental health outcomes among people who smoke. So really a wide range of analyses. And I think that what's really nice here is that the cohort is able to supplement some of the epidemiologic data that the health department has, because generally they don't have such detailed information about comorbidities and some of the other outcomes that we're able to capture. So one unique aspect of the cohort, as I mentioned, is this linkage of our electronic health record data with DC Department of Health surveillance data. And this linkage really allows us not only to enhance the completeness of both databases, but also to capture diagnoses in labs that might not be captured in the clinical records, as well as to refine our care continuum estimates. So this is an example of one of the linkages. You can see from the pie chart on the left-hand side that, about the vast majority of participants seem to get care for their HIV at one site. However, about 23% do get care at more than one site. And when we looked at the HIV care continuum and stratified it by the number of care sites that people were using, you can see all the way on the right-hand side that there was a significant difference between viral load suppression and the association between viral load suppression and the number of care sites. Other linkages we have done have helped us identify about 600 new STI diagnoses. And in our last linkage, we were able to identify about 600 deaths that were not captured in the clinical data. Another feature of the cohort is access to a clinical dashboard. We use this to feed information back to sites regarding key EHE indicators as well as clinical outcomes. So the dashboard provides timely and kind of aggregate data to our providers. It gives them useful information that they can use to take action. They get this data on a quarterly basis. And When they log into the website, they can actually see their data compared to everybody else's data. They're able to stratify participants by certain demographics, as well as download individual patient level data to which they can have access to and hopefully, improve care outcomes. I'll show you a couple of examples of how we're able to use the dashboard to monitor EHE progress. And then we also on the back end are collecting what's called para data. So we're looking at dashboard use data to assess whether there are any correlations between providers using the dashboard and quality of care improvements. So here are data from the dashboard that are showing the distribution of participant status. So this is as of March of 2024, we had 12,687 people who were actively enrolled. Again, you can see that about 52% of them were actively engaged in care. Another 22% were not in care, and about 11% had died since they had enrolled in the study. On the right is the part of the landing page for the DC cohort dashboard. And again, you can see that sites can select which quarter of data they want to look at. As well as importantly, they can actually go to that inactive participant listing and they can download a list of participants who have not had any evidence of HIV care and or any HIV related labs, so that again, hopefully they can work with their patient navigators, their Ryan White care teams, et cetera, to re-engage those people into care. With respect to the EHE progress, we have lots of different metrics that we use in the cohort dashboard, but I'm just showing you a couple of screenshots. So we're able to look at prevention by tracking individuals who have been using PrEP prior to seroconverting and enrolling in the cohort. We're able to look at diagnoses by monitoring late diagnoses among people with HIV. We're able to look at treatment by looking at receipt not only of antiretroviral therapy, but we can more specifically drill down and make sure that people are getting combination ART that's recommended by the HHS guidelines. And we're also able to look at treatment in terms of viral suppression among people with HIV. We've used the certain color scheme in the dashboard. So orange is indicating something that's actionable and that we hope that the providers and care teams will go and drill down and look at who those individuals are, again, with the goal of improving quality of care. The dashboard kind of gives everyone a snapshot in time for that quarter, but we're also tracking longitudinal measures as well. So this is just one example where we've been tracking time to ART initiation from diagnosis and then time from ART treatment to viral suppression. And you can see that from 2013 to 2023, we've seen significant improvements and shortening of both of those really key indicators. And then in terms of the respond pillar of EHE, we've been able to conduct a molecular epi sub-study using the cohort. And so the first kind of activity that we did was to work with our colleagues in bioinformatics at GW to look at the pairing of sequence data and some of the clinical data. They were able to identify that 90% of sequences of people in the cohort were subtype B. So inferring a US-based epidemic, we have quite an international population, and so we were interested in understanding what the subtypes look like. They were able to look at clustering of sequences using different approaches and found that we had a lot of dyads, but we also had some clusters that included up to 32 people. And then we were also able to do some geospatial mapping and found that the highest rates of clustering were actually in areas of highest HIV prevalence in the city. We also were able to collaborate with Joel Wertheim at UC San Diego using HIV Trace. We were able to collect some behavioral data on individuals who were in the cohort, specifically focusing on people who were newly diagnosed and individuals who were not virally suppressed. We recruited individuals. We had them complete a behavioral survey as well as a blood draw to do sequencing. And that analysis and that work resulted in the identification of about 28 clusters that had had 3 or more sequences. Interestingly, none of those large clusters included any newly diagnosed people with HIV. And then behaviorally, we were able to determine that about 34% of our participants were reporting condomless sex during their last sexual encounter, again, of concern for us in terms of onward transmission, and about 14% reported a syphilis diagnosis in the past year. So the implications of this study were that, we were able to really kind of triangulate that HIV sequence data, that clinical data, and that behavioral data to provide some insights into HIV transmission, and that behavioral survey data really complemented our clinical data and allowed us to better characterize these transmission clusters. Since that work has been done, we have now integrated patient-reported outcomes surveys into the DC cohort study so that we have at baseline, everyone completes a PROS, and then annually they complete that as well. So then we got to the COVID-19 pandemic. So I think it goes without saying that in March of 2020, all of our lives changed with the declaration of this pandemic. I think that for those of us in the HIV field, we had a lot of momentum. We thought we were on this kind of fast track to ending the domestic HIV epidemic. And then, everything kind of came to a screeching halt after the pandemic was declared. I know personally, and many of my colleagues, and I'm sure many of you, both working in public health and as clinicians and researchers, were really detailed to assist with these COVID response efforts. Personally, I ended up, kind of using my EIS training and my work with health departments to assist with response efforts at DC Health and as well as Montgomery County Health Department, which is just next to us in Maryland, and then also ended up assisting with reopening efforts at GW starting in July 2020. I think, while it was kind of fascinating to be on the front lines and to really watch the pandemic unfold, and, I think it obviously was very clear that there were many unknowns for all of us. And for those of us working in HIV, there were certainly a lot of unknowns with respect to HIV. We didn't know if people with HIV were at higher risk for severe SARS-CoV infection. We didn't know how these stay-at-home orders would impact access to HIV services. We didn't know what the incidence of COVID and long COVID might look like among people with HIV, and how they would be impacted, financially, mentally, what were their lives? What was the impact of the pandemic going to be on their lives? And then also, what would the uptake of COVID-19 vaccines look like among people with HIV? So again, based on our really strong collaborations and partnerships, we were actually able to leverage those relationships, the platform of the cohort, to be able to address some of those questions. And we actually ended up getting supplemental funding from NIH to conduct a cross-sectional survey among about 2,300 people who were in the DC cohort to ask them about COVID-19. So first, we sought to determine how many people in the cohort were at higher risk for COVID-19, and we concluded that a high proportion of participants across all these age groups would be considered at increased risk, about 58%, or high risk at 34% for severe COVID-19. Next, we looked at the impact of COVID-19 on HIV service utilization, specifically looking at encounters for HIV care as well as HIV RNA tests. And we found that between 2019 and 2020, actually, we were surprised to see that the number of encounters increased, but laboratory utilization decreased. And then when we looked further, we found that about 2/3 of HIV care encounters between March and June of 2020 were actually remote encounters. And so we think that these findings really indicated that increased uptake of telehealth visits, and that the decrease in labs was probably because there was kind of a separation between, getting your telehealth visit and then having to get yourself to the lab to get tested. We also used the survey data to measure the incidence of COVID among cohort participants. So the graph on the left shows self-reported cases of COVID-19 during the different waves of the pandemic. And based on survey results, we observed about a 17% incidence of COVID infection among people with HIV, of which about 7% required hospitalization. And then internally, we tracked the number of COVID-19 cases based on ICD-10 codes. And so we had kind of our own internal dashboard. And you can see here that as of August of 2023, we had about 1,200 reported cases of COVID-19 based on relevant ICD-10 codes. We also just recently published data looking at post-COVID conditions. And so in this analysis, we were able to look at the prevalence of post-COVID conditions and found that about 46% of our participants who had COVID also reported symptoms consistent with PCC. This graph is a little bit busy, but the point here is just that we did look at activities of daily living among those individuals with PCC versus those without. And we saw statistically significant differences observed between those with and without long COVID with respect to their ability to complete vigorous or moderate activities, their ability to climb stairs, to walk certain distances as well. And then finally, we were able to leverage the cohort to understand the impact of the pandemic on the lives of individuals living with HIV. So we assessed kind of the psychosocial impacts of the pandemic on participants. And in the table on the left, you can see that about 56% of our participants reported some type of negative impact in terms of their finances or employment. A very high proportion, about 78%, reported increased mental health impacts. About 52% reported a decrease in social connections, and 18% reported an increase in substance use. In addition, we all know that there was a lot of misinformation and disinformation circulating about COVID and with regard to COVID-19 vaccines. And so we also were interested in looking at uptake of vaccines among our DC cohort participants. And so while about 22% of our participants were vaccinated, we certainly identified major barriers to vaccination. Again, highlighted in red, you can see that the vast majority of those that were hesitant didn't trust the government, felt like the vaccines had been developed too quickly, or were concerned about side effects. So then again, as we all know, in the summer of 2022, just when we thought we were emerging from the COVID-19 pandemic, the monkeypox or Mpox outbreak reached the US and reached DC. DC at one point had the highest Mpox case rate per capita with over 500 cases reported in the district. The stigma around Mpox was pervasive and very reminiscent of the early days of AIDS and HIV. But nevertheless, I really want to laud the DC Department of Health and their response. It was culturally sensitive, it was comprehensive, and swift. And, it was recognized by the CDC as one of the best responses that they had observed. Their approach included rapidly making vaccines available to anyone who reported having recent sexual partners and not limiting vaccine availability just to those individuals who were considered to be, quote unquote, at high risk. And the vaccine was available at multiple community-based clinics, walk-up clinics, and during Pride events as well. And I think that made a huge difference in the ability to get vaccine out to those individuals that needed it. So when it became clear that Mpox was disproportionately affecting people with HIV, again, we kind of pivoted to use the cohort as a platform to really measure the impact of Mpox on people with HIV and vaccine uptake. And in August 2022, we surveyed about 500 DC cohort participants. We found that a higher proportion of men who had sex with other men were reporting limiting their number of sexual partners or only having sex with a certain group of people, as well as kind of talking with their partners about Mpox symptoms before having sex. And then we also tried to look at the measure Mpox vaccine uptake and found that when we compared people who were vaccinated and those who plan to vaccinate to people who didn't plan to vaccinate, that age and being younger, basically, and being a male who had sex with other men were also significantly associated or had a higher, predictive probability of getting vaccinated. So younger people with HIV and men who had sex with men had a higher probability of vaccination. So I've given you kind of a lot of different examples of some of the work that we've been doing. And I just want to share a few kind of thoughts about lessons learned from these types of partnerships and fighting these types of pandemics and outbreaks. So the first is that I would say that partnership with local health departments in both applied epi and implementation science is really necessary if we're going to have a meaningful impact on the HIV epidemic. I think that, you know, the e-chip work, and we had these care continuum working groups, and these applied epi studies were really precursors to a lot of the EHE efforts that are now underway. I think, you know, health departments are really extremely knowledgeable, not only about the programs being implemented throughout the local level, but, you know, they know their community organizations, their stakeholders, they know the breadth and depth of clinical services being delivered. And so they really are uniquely positioned to be able to support both implementation and the sustainability of these implementation science-driven interventions. The second lesson I would say is that community engagement is really integral to developing our public health responses, and that we have to have community involved from conception to implementation. Our experiences with the rollout of the COVID-19 vaccine, I think, and Mpox vaccines as well, really are great examples of where if we had had more deliberate and early engagement with community, that this may have kind of streamlined our approaches. We may have been able to anticipate some of the issues that came up with respect to vaccine uptake and equity, and you know, identifying trusted key opinion leaders, ensuring that there is adequate health literacy around some of this. I think that meaningful community engagement is just really key. It's something that is dynamic. It's something that's cyclical. It's something that's sustainable. And, you know, our Center for AIDS Research has been really kind of, I think, a leader in this in terms of creating models and really identifying how to have meaningful community engagement. The third lesson I would say is that collaboration and input from frontline healthcare providers has allowed us to better understand and design effective service delivery models and interventions. So, you know, whether we're speaking to clinical providers, social workers, case managers, nutritionists, whatever supportive staff, as we think about the design of these clinical interventions, we have to think about their systems, their policies, that infrastructure in which these services are going to be delivered, and also about the variability across clinics. I think that the work with the cohort and having these 14 very diverse sites has really kind of brought that home for me. The fourth lesson I would say is utilizing multiple data sources is really essential for rapid response, decision-making, and action. So since our early work with HOSTA to use surveillance for action and to use it for, you know, other than just kind of counting cases, I think that that has been really critical. And again, I don't think we're the only place to do that. I certainly know New York City's doing that. San Francisco, University of, or Seattle, King County has done that very effectively as well. I also think that results from our research studies have informed the development of local, I know they've informed the development of local HIV, COVID-19, and Mpox programs. And that kind of the ability to triangulate these data has provided a more comprehensive picture of the impact of these outbreaks and pandemics. So data dissemination really has to be key, not only to engage community, but to engage the health department and clinicians in their ability to respond as well. And then finally, I'd say that, leveraging kind of the novel systems, the collaborations that have been put in place and the infrastructure created in response to the COVID pandemic and Mpox outbreaks, I think will actually strengthen our current responses to HIV, even though they initially kind of, I don't want to say they derailed us, but they took us in a different path for a couple of years. I think, it's clear that our HIV care delivery systems have changed forever. I think that there's, now more emphasis on integrated care, co-location of services. We see a lot of home-based testing. And so these are all programs and approaches that I think are here to stay. I think that we'll certainly have to do some systematic evaluation about what works best and what doesn't. But I think that we can take what's been built and help that to leverage our ability to end the HIV epidemics at a local level and nationally as well. So in sum, I think DC has been, certainly has been one of the epicenters of the HIV epidemic, but also the COVID-19 pandemic and the Mpox outbreak. Our multi-stakeholder partnerships and collaborations have really helped inform our responses to curtail the impact of these various pandemics, epidemics, and outbreaks on people living with HIV and also those vulnerable to HIV. And while COVID-19 and Mpox really diverted our efforts towards achieving our EHE goals, I think they also, in a good way, in a positive way, forced us to innovate and adapt. And collectively, these experiences, I think, will help inform and assist us in ending the HIV epidemic. So I am just one person on a huge team of people. I certainly want to make sure that I acknowledge my close colleagues at GW and the Department of Epi, my team that runs the DC cohort, my longstanding colleagues, both past and current at DC Health, not only at the HIV/AIDS, Hepatitis, STD, TB Administration, but also the Center for Policy Planning and Epi, because they really help lead the response for Mpox and COVID-19 as well. Our partners through the Partnership for AIDS Progress at NIH, and then, of course, the funders for all of this work. So with that, I will say thank you for your attention. And this is my email if anybody wants to reach out, and I will stop sharing so that we can have some discussion.